task that we have now is like not to identify where the seizures they come from, but where they are located, what we call pathological hubs of these networks, in order possibly to resect these networks, these hubs, and the patient to become seizure-free. To give it in an example, is like being in a busy area or a big metropolitan area, and you have a traffic jam in the whole area. And maybe sometimes this is because like there's some constructions or some kind of an accident in a specific critical intersection. And if this will be fixed, then the whole network will be fixed. So in a similar way, we believe that like in the epilepsy, there's critical hubs that if we are able to resect or intervene there, the brain will not seize anymore.
Welcome to Epilepsy Sparks Insights. I'm your host, Tori Robinson, and today I am joined by Dr. Christos Papadelis, who's going to be sharing with us how ultra-high resolution brain mapping and AI are transforming how we identify seizure onset and improve surgical outcomes in children with drug-resistant epilepsy. We get into what precision really looks like in practice, using a combination of more than 550 ultra-high density EEG and MEG sensors to localize seizure activity with far greater accuracy than traditional approaches. If you're new here, please subscribe so that you don't miss future conversations. And let's get into today's episode, presented in partnership with Easy by Prosthesis GmbH.
We work on two main areas of epilepsy. One focus on children with drug-resistant epilepsy. As you know, like approximately 30% of the children with epilepsy, they are unable to control their seizure with drugs. And one of the best available options for these children is epilepsy surgery. And it's a critical epilepsy surgery to be performed early in life because the child's brain has high levels of neuroplasticity. So there's plenty of time like for the child's brain to rewire and reorganize. With my team, we develop innovative tools and methods that help us to identify with high precision the area where the seizures they come from, what's called epileptogenic zone. We use like different kind of methods. We use like non-invasive techniques, and we're one of the places in the world that have this unique setup that allows the simultaneous recording of the magnetic and electrical activity generated by the human brain by using more than 550 sensors covering the entire child's head. We combine two different techniques. One technique called MEG or magnetoencephalography. It measures the magnetic activity of the brain. And then we combine these findings with a high-density EEG. It's a technology with a high number of sensors that measure the electrical activity of the brain. And by bringing these two techniques together, we have a really high precision to localize where the seizures come in a child with drug-resistant epilepsy.
Could you just tell us how many, because I know you said 256 electrodes in the ultra-high density EEG. Could you say that? Because people will be like, oh my God.
For the high-density EEG system, we use 256 electrodes. We have a kind of a system that is very child-friendly. You don't have to put individual leads for the EEG. As in the conventional EEG, we use nets, and these nets, they are made out of electrodes that have attached to them sponges. We soak the whole net in a bucket of water. Then all these sponges, they become conductive. We place the net on the child's head. In the first 10 minutes, we start performing EEG recordings with so high number of electrodes.
This is so cool because I think most people who don't know much about these advanced EEGs, they just think of the scratchy stuff that they have put onto their scalp and then have a few electrodes just plonked on there, and it's really annoying. But to have something just plonked into some water, it doesn't electrocute anybody, and then have that put on your head, especially as a child or especially as somebody, I'm generalizing, but say, for instance, somebody with autistic traits or something, that must be an amazing positive alternative.
Yeah, it's very helpful for the children. And then most of the recordings, they are quite straightforward. Also, MEG technology is very child-friendly because if you perform MEG by itself without the high-density EEG, there's no need to place any kind of electrodes on the child's head. It has a helmet, and then the child's put its head inside of this helmet and lay down on a bed, and in a very quiet environment with no noise or any kind of interference, like sleep for an hour. and we are able like to record this activity from the brain and localize in several cases with high precision where the seizures they come from.
So cool. And then I believe you combine the data collected from the MEG with the data collected from the EEG to make something beautiful and have good insight into the activity and identify the epileptogenesis. Is that right?
We use a new technique called electromagnetic source imaging. So we combine findings from these two methodologies into a single solution. And then this helps us like to improve the accuracy that these two techniques they offer. Because these two techniques, they have different kind of like sensitivity profiles, what we call. They can localize generators in the brain that with different kind of like sensitivity. So we combine findings in one solution, and then this gives better localization.
Could you give us an example of a child that you've worked with and what the outcome of this may have been?
Oh, yeah. We had a fascinating case where my team helped a child with drug-resistant epilepsy who struggled with this kind of disorder for more than 16 years. And the patients visited different hospitals in the United States with no success. They had different clinical teams. They would not be able to identify where the seizures they were coming from. And eventually she came here to Cook Children's, and we helped the clinical team to solve this difficult case. My research team was involved heavily into this case. We performed MEG and high-density G recordings. We identify that the seizures that were coming from insula, it's one area in the brain that is a little bit like deep, and it's more difficult to capture activity from there. We present this evidence to the clinical team. The clinical team was convinced that we have a case there, and then they place intracranial electrodes invasively to confirm that's the case. They found out that indeed seizures that were coming from this location. The child was ablated with laser. And that's also another technique that Cook Children's we are really innovative. And the child is seizure-free now for 5 years.
Just to give people perspective, often people with an epilepsy have symptoms other than seizures. How are they doing otherwise?
Not only seizures, and patients with epilepsy, they don't deal only with the seizures. That's the main component, what is the most well-known and described. But they have several other comorbidities. Several of the people with epilepsy, they have intellectual disabilities. They struggle at school. They have depression. They have anxiety, and there's a whole group of comorbidities of epilepsy that also needs to be studied. Just to put in the perspective, and then the case I described before, the child that we managed to help with the seizure freedom eventually developed depression and anxiety after the surgery. So this is a comorbidity that we need to try to examine more and find out how we can deal with that.
Well, I understand you're working with somebody who's actually got a project about those morbidities.
Yes, in my team, we have a principal investigator, Crystal Coopers, is working with children with epilepsy comorbidities, and she's trying to understand the different kind of concepts of emotional processing in the brain of the children with epilepsy. We try to develop now more projects for these comorbidities. Also, we work closely with the clinical team here. Dr. Scott Perry, he's our clinical partner, and we work closely together with the clinical team to help children both in the pre-surgical evaluation, but also in the epilepsy comorbidities.
Fabulous. So you're looking at the overall quality of life of the person. You're not just looking at trying to stop somebody's seizures from occurring.
To add on that, now we have new also ideas and understanding how the brain works in patients with epilepsy. We found out that in several of the cases where we don't know where the seizures they come from, it's really hard to identify the epileptogenic, what we call epileptogenic zone. Then now we believe that there's a whole network in the brain that is responsible for the generation of the seizures. The task that we have now is not to identify where the seizures they come from, but where they are located, what we call pathological hubs of these networks in order possibly to resect these networks, these hubs, and the patient to become seizure-free. To give it in an example, is like being in a busy area or a big metropolitan area, and you have a traffic jam in the whole area. And maybe sometimes this is because like there's some constructions or some kind of an accident in a specific critical intersection. And if this will be fixed, then the whole network will be fixed. So in a similar way, we believe that like in the epilepsy, there's critical hubs that if we are able to resect or intervene there, the brain will not seize anymore.
Are you saying that there's the potential, at least in the future, to consider surgery for more than one hub?
There are some cases that we know, for example, that the seizures, they come from one location or from multiple locations. But sometimes like these areas, they overlap with what's called eloquent cortex, is the area where which are very critical for the functions of the child, and that we should not resect. For example, if we resect or we intervene with the motor cortex, then there are potential motor deficits for the patient. But what we can do, we maybe like resect or intervene in the neighbored area that is not so critical for that, but it's critical for transferring or bringing the seizures like in the whole network.
Before we move on, with thanks to Easy by Prosthesis GmbH. You have a paper related, Machine Learning on Interictal Intracranial EEG Predicts Surgical Outcome in Drug-Resistant Epilepsy. Tell us about that.
This is a paper we published recently with one of my postdoctoral research fellow here, Ahmayak Partamian. So this paper, it's about using artificial intelligence technology for helping analyzing the large amount of data we collect from patients with drug-resistant epilepsy. We usually, in several of the patients, we put intracranial recordings. We put electrodes inside of the brain in order to identify where the seizures they come from. And these recordings, like they may last like for days or even like weeks. We're actually waiting for a seizure to take place. But this kind of investigation, because they also have some risks for infection, for other kind of like injuries in the brain. So with my team, what we did, we analyzed data between seizures, what's called interictal activity. And by using artificial intelligence tools, we try to use this kind of like recordings in a fully automated way without using like the clinical team or the epileptologist spend time reading all this complicated data to identify where the epileptogenic zone is located. And we found out that like resection of this area can predict surgical outcome of the patient with drug-resistant epilepsy.
I was speaking to another person with an epilepsy recently who, the moment I mentioned AI, was like, oh my God, I don't trust AI. I only trust a clinician, physician. And so could you tell us why we should trust that AI? And also, would the data or assessment of the data that you've just explained, would that be shared with the person's a neurologist or epileptologist or neurophysiologist as well?
I don't see the AI as a tool that will replace the clinicians or the epileptologist, but is an AI. The AI tool can help us also guide us in a specific direction and be a really useful tool in the busy schedule like these people they have in their everyday life in the clinical care of the patients. When we have intracranial recordings from patients for hours or even days, then usually we have a technician who is like going through all these recordings, try to identify where the seizures they occur, try to make clips of these recordings, and then provide this information to the epileptologist. By using AI technology, we're trying like to help all this process, make it like much more efficient, and also like guide the epileptologist like to, in a sense, to see where this is they come in the brain. And AI is as a tool is used now in other kind of fields of medicine with really high success. There's some articles, for example, that how AI they can use radiologists in identifying the cancer findings in lung X-rays, for example. In a similar way, I believe that like what we can do with AI technology, we can help the epileptologist like to identify patterns on either in the scalp EEG or in the intracranial recordings. where the seizures they come from, which locations they are in the brain, or this kind of like networks that are responsible for the generation of the seizures.
It just can help us and find out things that humans don't see, for instance, and then we assess all the data and the suggestions after the AI analysis has been made by AI.
And also the AI, if I can mention that too, like the AI is a tool, and this is a project we are working now. Like it's not only important for identify where the seizures they come from, but also, like as I mentioned before, like also to identify these functional connections in the brain in order to be able like to find these critical hubs. We have a paper published recently with one of my postdoctoral research fellow, Ludovica Corona, on functional connectivity in the brain. Actually, by using MEG and high-density G, we're able like to identify these critical hubs in the brain of the children, and we saw that like surgical resection of these hubs can predict surgical outcome and make the patient seizure-free.
Amazing. I'm thinking of my own personal experience, and I wish I'd had access to this as a child. It's amazing that some kids can have this these days. Obviously, it's not available to everybody, but I think it gives us a bit of hope for the future, for the children of the future, who will then become adults.
I strongly believe that we have so advanced technology nowadays for helping patients and children with drug-resistant epilepsy. Neuroimaging techniques, they have advanced significantly the last 2 decades. We have new softwares, new tools that can help the clinicians and the patients for helping this population. But what we're lacking now, we're lacking of funding on how to translate this kind of knowledge that we have from the technological aspects into the clinical practice. There's a gap there. And then we need help on how to take this knowledge that already exists at the technical level and help by using this knowledge how to help the children with drug-resistant epilepsy become seizure-free, and also like not having all these comorbidities they struggle with epilepsy.
Getting it to the people that need it, to the patient, it's otherwise, what's the point?
Yeah. Something I've learned, like I'm a biomedical engineer, that's my background. And something I have learned in my career so far is that biomedical engineers, they have like really great knowledge about the tools and the methods. Clinicians, they know very well how to deal with the patients, but the way how these two groups they interact is somehow like not efficient. We need more work to how they talk to each other. What is the importance there? The importance of the different problems, and how they can eventually all these tools like they can be translated to have clinical impact to the patient.
A huge thank you to Christos for sharing his experience with us. One of the most striking takeaways here is that we are moving beyond simply asking where do seizures start to understanding the networks and critical hubs that sustain them, and that shift has real implications for surgical strategy and outcomes. Christos has also highlighted for us a major gap, not in technology but in translation. The tools exist, but the challenge now is getting them into clinical pathways so that more children can benefit earlier when their neuroplasticity offers the greatest opportunity. Thank you also to Easy by Prosthesis GmbH for supporting this episode. If you found this episode helpful, please give it a like and subscribe, and hit the bell so that you are notified when new episodes drop. I would also love to hear your thoughts or experiences in the comments below, because I do actually read them. Thank you for joining us, and see you next time.